I think now we can shift to the second half of this session, surgery, and I will ask my dear Professor Fahim Bassiouni. Dr. Fahim Bassiouni is the most senior professor of laparoscopic surgery in Egypt, and he is really one of a kind, the wise surgeon. He is not an excellent laparoscopic or obesity surgeon, but really, I was a resident and he was an assisted lecturer, and we were competing with each other who will have the privilege to work with Fahim Bassiouni. Really, he is the ex-head of Egyptian Laparoscopic Surgery Association and the Middle East Laparoscopy Association, and really he is a wonderful trainer as well. Professor Fahim, you please chair with Professor Tamer Nabil this session. Professor Tamer Nabil is the head of endoscopy endosurgery unit at Bani Suef University, and Professor Tamer really he helps every laparoscopic surgeon in Egypt, young and old laparoscopic surgeon, and he had what you call the advantage of with some colleagues to make what is called Bravo Academy. Bravo Academy is responsible for training laparoscopic surgeon in Egypt and Middle East for obesity surgery. So please, Professor Fahim and Professor Tamer, lead this session. And we were talking a few minutes ago with Dr. Fahim that Professor Hassan Shakir apologized. He will not be able to deliver his lecture. So we have Professor Ali Ghelai from Libya, the famous academic professor there. And Dr. Fahim and Dr. Tamer, please take the session into your control, Professor Fahim.
Bismillah ar-Rahman ar-Rahim. First of all, you can hear me, right?
تمام.
Well, thanks should go to you yourself.
Allah يخليك.
Muhammad Yusuf, yes, Muhammad Yusuf is an old friend since maybe 1978, very long time. And he is, you can say, a source of ideas. مش سامعينك. I can't hear you.
No, 1981.
70. Oh, yes, 81. Yes, right. Anyway, he is a big source of ideas. His ideas never end. And talking about this situation, medicine under siege, is something that's extremely important and also in its time. And I'm happy and privileged because of the selection of my brother and deep friend, Ali Ghelai. Ali Ghelai used to come to the conference of the Egyptian Society of Laparoscopic Surgery long time ago. Probably in the last 5-6 years, he is not coming, and I'm inviting him on air to come next Congress in February 15 and 16. He is, as Professor Yusuf said, he is an academic person. He is one of the best teachers and trainers, and he is a marvelous surgeon, and he is Libyan, which is something very close to us in Egypt. As Yusuf said, we were supposed to talk about surgery in low resource countries or under situation and diagnosis. And probably now Muhammad Yusuf corrected the situation, because Professor Ghelai will start by diagnosis of surgical conditions in low resource countries. So please, Professor Ali, go ahead.
Okay. Thank you so much, Professor Muhammad. Thank you, أحبي Professor Bassiouni, وشكرا للكلام الجميل. So today I'll be talking to you about overcoming barriers in low resource area. And I want to start by mentioning the quote from the Director General of WHO, Dr. Mahler, in 1980, who said that the vast majority of the world population has no access whatsoever to skilled surgical care, and little has been done to find a solution. It was estimated in 2010, the WHO estimated about 17 million people, about 1/3 of the whole world death. 17 million people lost lives because of lack of safe surgical care. This was exceeding the combined mortality rate for HIV plus tuberculosis plus malaria together. Another shocking fact that there are estimated 5 billion people lack access to safe and affordable surgical and anesthesia care when needed. So in low and medium income countries, 9 to 10 people cannot access basic surgical care. For example, in rural Bangladesh, there is only one doctor for 10,000 people compared to 18 in urban area. To have a safe surgical care, patients need and should be able to reach in a timely manner. However, reaching a hospital does not guarantee treatment because many hospitals lack infrastructure to perform emergency surgical care. And to have safe surgical care, I'm gonna stop. Do you hear me now? Are you hearing me? So I continue.
We are hearing you, Prof.
Okay. So
yes, we can hear you. Yes, proceed.
Great. So we need to have it reach, make sure that we get the service, and the cost is not going to be a burden or a barrier for the families. And therefore, there are 3 types of delays can happen. So I'm going to give an example of a patient with an who needs appendectomy, appendicitis. One delay, the first time, there are 2 types of delay. One type of delay is delay in seeking care, which means the people that lack healthcare education or financial barrier or social barrier. The second type of delay is delay to reach care. That means the distance is far or the cost of transport is high. The third delay is delay for receiving care, where we have a delay in diagnosis or lack of infrastructure or resources to treat. And this delay can be multifactorial, can be financial, geographical restriction, political, cultural beliefs, poor education, lack of awareness of services, or low confidence in your services. I want to tell you that 95% of people in sub-African Sahara, they don't have access to surgical service. And there is roughly in the world about 1 surgeon per 200,000 people. In the sub-African Sahara, it's 5 times fewer, 1 surgeon per 1 million people. Just to understand what that means, in Vienna, Austria, there are 196 surgeons per 200 people, 200,000 people. So the problem is not only that. Hospitals often lack running water, stable sources, and electricity, and access to roads. To make a good diagnosis, there are resource shortages for equipment, supplies, which need to be reused and are unavailable. Surgeons from this area leave their home country to the West to be trained. They train on using equipment that will not be available at their hometown. This will make them not go back home. All these barriers create barriers to access safe and reliable surgery. On top of this, diagnostic is a problem. We know the fundamental basis of evidence-based treatment is to find the cause of illness. And a reliable and accurate diagnostic investigation play a role in your decision. And when I say diagnostic, I mean radiology, pathology, and lab together. The diagnostic errors are considered the #1 cause of malpractice claims nowadays. About 10% of deaths in the hospital is because of diagnostic problems. And the cognitive errors, which is التفكير. دكتور بسيوني هل أتكلم بعض الكلمات بالعربي أو نستمر in English?
It's better to speak in English, Dr. Ali.
So the cognitive errors are important source of diagnostic errors in almost 75% of cases. In one study done by the Harvard Medical School hospitals, it was found more than half of the malpractice cases due to assessment failure. That was narrow diagnostic focus, failure to establish a differential diagnosis, or relying on a previous diagnosis. In a study, a CRICOT report on a 23,000 malpractice cases, 1 out of 5 patients, five malpractice cases were attributed to diagnostic errors. And 75% of these errors are due to lapse in clinical reasoning. That tell you how important is that. We have the saying saying that dogs can't, but cats can. Which means I'm trying to allude you to that CT scan is an essential in the correct diagnosis. However, it's not available in most of our remote areas or the low, or not available easily available in low and medium income countries. So I want to discuss the importance of CT in low and medium income countries and replace CT scan by CT for critical thinking. So if we apply critical thinking in the correct, lead to correct diagnosis and lead to safety. And the critical thinking is the basis of any medical education in the past. It is critical thinking and problem-solving strategy. It is how doctors think. It is the skill of making the right diagnosis and recommending the most appropriate therapy. It is the goal-directed thinking. So to make the diagnosis and treatment better, more clear, more accurate, more defensible. However, as Henry Ford once said, thinking is the hardest work there is, which is probably the reason why few people are engaged in it. And we notice a lot of people who don't want to think, والله ما بيدرسوش بيشتغلوا hard muscular work. Some of us, and even for our surgeons and my trainee, they don't want to take mental exercise. They just jump to a conclusion. So going back to say that critical thinking is the ability to solve a problem by making sense of the information used creatively, logically, and analytically. And you continue doing that till you reach to the closest reasoning for that. And it is divided into clinical reasoning and clinical judgment. But remember, to have it done correctly, it may involve good communication and collaboration with other team members, especially for complex cases, which I'm trying to allude to multidisciplinary approach in the planning of care. So I said it is both reasoning and judgment. We call it reasoning when we refer to the way of thinking, like when determining the disease, prevention, and management. So there are diagnostic reasoning and therapeutic reasoning. But when we talk about clinical judgment, we are referring to the outcome. So the process is critical thinking and critical reasoning. The result and outcome is clinical judgment, which is the decision and opinion. And this need the combination of learning about the patient, reasoning the information, thinking creatively, generate and evaluate idea, making decision, solve the problem. And I want to tell you, it is just similar to I'm saying going into 8 steps. So I keep saying this to my juniors, that it is about thinking, about my thinking while I'm thinking. So how we think, how senior or accomplished surgeons and physicians do. First, they look at the patient and the data they have. Then they collect data by history, physical labs, and imaging, and whatever they can do. Collectively, talk to people, read records. And then they process that. When I say the process, they put it inside the brain, put it in, analyze it, and put it together. Then they decide on the what this means and what then. And then make a differential and make a treatment plan. Based on this treatment plan, they act and make a treatment and act on that. But they have to evaluate, am I on the right track? Am I having good response? And get a feedback and reflect. So it is a circle like this, which you keep doing it multiple times. So to say it simple, just concentrate with me in this. I have my brain there thinking. I collect data from the patients into my brain, compare it to book knowledge that I acquired through my education training. This has to go into my brain into a process of interpreting and analyzing the data, relating information with each other, discriminating and distinguishing relevant from irrelevant information, inferring, yani تستنتج, making deductions and making opinions, match current with the past situation, predict an outcome and make a decision. So here you make a diagnosis and differential and therapy there. This process, which is in violet there, move color, you have to teach it and you have to practice, and we have to do it in our education. However, when you do that, it's not about yes or no. So if I go to previous slide, it's like my brain is a computer. It's like a Google. I'm gonna search the information in my brain. So I need to have the right keywords to pull them out. And remember, the keywords is the essential for searching the literature. The keywords essential for searching my knowledge in my brain and correlating with the information. And I'll come to this in a minute. But when you come to a conclusion, it's not about yes or no. It's about probability. So for my diagnosis, I don't say it is this. It is this is very likely, maybe, unlikely, very unlikely. And then I cut a threshold. In the green, which is very likely, means it's a treatment threshold, and I may proceed with ruling in and treating with minimum investigation. When it is in the very unlikely, I can save myself doing a lot of tests by ruling it out, or we will call it today, trash it out, put it in trash. Those who are uncertain is likely and unlikely. But where should I put these cuts? So to be honest, it's easier to do it instead of do it in numbers, which is hard. I will do it this way. It is the likelihood is high, medium, low, or no. And then I put my cuts there. I treat, I rule out and trash, or I have a suspicion, let me test it. Where should I put these two cuts, the treatment and testing? It depends on the condition, how serious is my differential in affecting the patient, how likely and how serious, and how difficult to get that test, or how expensive to do that test, or how invasive is that test. So there are other factors. We discuss it in a separate time. So that's the most important. So now I take a history, I get the data, and I analyze all the information in my brain by making hypotheses. I test it, and either I trash it, or I treat it, or I'm still in doubt. Then I go back and test it. How I test it? Acquire more information. I may do more physical exam. I may get more detailed history. I may get more tests and put another hypothesis, doing it and going back. Trash it or treat it. And if I not, I go back, and it's a loop of circle. I keep doing it on and on and on till I reach my diagnosis. So in short, critical thinking means I'm making a sound judgment. It requires a combination of my knowledge and connecting it with the information from the patient, which I described. So this combination, which I explained from here, unless I have a keyword, the data saved in my brain in keywords. And these keywords, we call it illness script. So Professor Bassioni and Professor Muhammad, who are great educators, I'll call that we need to teach our students and residents to have illness scripts about each disease in their mind. So whenever there is a red flag or there's a flag raising up with that word, I suspect that disease. So this script, it is like في أيامنا القديمة library cards. They're small 3x5s that they have main things. What's the most common epidemiology and risk factors? What's the common signs and symptoms? What's the time course and pathophysiology? And I develop when I am a resident or a student. With age, I'm making it more data till become bigger. Now, for me to get that activated, when I search, when I present my history, when my resident present the history to me, has to use the same terminology. So we need at the end of history and physical, have a summary statement that use the same terminology, which can open the folder in my brain, the computer, so it open that disease. So the illness scripts is nothing but a red flag. These are dynamic. You fill them up with time. So again, in the clinical reasoning, it's a process of getting data, converting it into a problem list at the end. I don't leave it as a, so at the end of my history and physics, I have to write a problem list and list all the problems they mentioned. There is a hypokalemia, there is abdominal distension with sepsis, there is dehydration, and there is tachycardia and hypotension, so might be a shock. I put them together, I put it into a statement. Then I generate a statement, and then I correlated with my illness script in my brain to give me a differential diagnosis. That changing of the history into problem list with a summary statement, we may call it semantic qualifiers. So an example, if I'm presenting at the down, if I'm exempting, for example, the patient will, let's say this in a medical term, not a surgical. I have, for the past 30 minutes, doctor, I have a chest, my chest hurts whenever I take a deep breath. So when I write it in my summary at the end of the history, I should write acute pleuritic chest pain. That will be in the present illness. But at the summary at the end, I should write acute pleuritic chest pain. That will ring something for me in my brain. If I have patient who say, of the past few months, several months, both my legs has been getting weaker and weaker, I should make it in the summary, patient has a chronic progressive extremity weakness that will stimulate. So you similar to that. The John with confusion, temperature 39, 20, blood pressure 130/60, respiratory 4, one partial pulse. At the end has severe sepsis. I don't know what's the etiology of sepsis. I have to look for it. Qualified as sepsis, which means acute surgery. I may use jaundice, fusion. So if jaundice, aside confusion and high bilirubin and INR, I write hepatic failure. So now it brings, I know what's the cause of hepatic failure. This is a way to start my thinking. Then I structure I structure my problem presented The whole history, physical with lab, should be, and I give you examples of summary here. Pain, work as like those, increased direct bilirubin and extrahepatic duct with filling defects. Oh, that summary for the whole thing, give me all obstructive jaundice, but can be, so it gives me a potential of things there. And another patient, 52 years old, female, who present with remote history of appendectomy and total abdominal hysterectomy. She presented with 3 days generalized colicky abdominal pain associated with vomiting and obstipation. I write the word constipation, no gas. So I'm clicking my brain. Physical exam, distended, non-tender, and high-pitched bowel sounds. Hernia site are in remarkable rectal exam. On abdominal, dilate bowel loops and multiple air fluid levels. Oh, us now can say the diagnosis. So this summary is my summarized 2-page history physical with an X-ray result and things. So you should summarize in few lines with 1 paragraph, no much of word, no noise, no extra information, only the most relevant, important information, which can lead to the diagnosis. And here you easily create a differential diagnosis. So what's the differential diagnosis and how we do it today? Differential diagnosis should not be very long. It should include one diagnosis, the one diagnosis that's the most likely provisional or working diagnosis. It should include 2 to 4 diagnoses which may represent the typical or atypical presentation of this. Also, though, should include any diagnosis. Do not miss diagnosis. So that's an important. And when I do test, I want to tell my young people, please order test after getting your differential diagnosis. And the test should be, unless you have a very rare few exception, only these 4 reasons. Either to rule in a differential diagnosis, to rule out a differential diagnosis that's reasonable to list earlier, or to look at the severity of disease or extent of disease or staging the disease, or to prepare for treatment, not for any other reason. In summary, the conclusion for that, just summarize it, healthcare, 1/3 of problem arise due to diagnostic error. Critical thinking help individual to differentiate correct information from incorrect information and make an accurate assessment. Knowing how to reason and think creatively, generate and evaluate ideas, see things in the mind's eye, make your decision and solving problem easier. So in short, critical thinking about having a problem, thinking about it, and making a solution. And I have to tell you that when we educate our people, we teach them 3 things. What to do, and that's knowledge. When to do it, and that's a judgment or reasoning or thinking, critical thinking. And how to do it, that's the skills. A lot of our people, they care about what and how, and concentrate a lot on how. In the lectures being shown, that I don't have about 75% of importance of a good surgeon is about what and when, 25% about how. And even the how, professors, certain procedure. It is about when to stop, when to do, when to locate this. So it's about what's this, what's that, what to do here. So it's about what, when, and how, even this how. So, and in the old days with this information, we used to have this taxonomy. We tell people, remember the knowledge, understand it, and the highest level of understanding is when we apply it. Nowadays, it's more than that. It's 6. Now, after apply to analyze the data, evaluate it, and combine the parts to get the number one and 2 from top list of people who need to be hired in the West now is creativity, problem solving, and critical thinking with communication. Here, when I see it, this one, here's I have somebody holding something very heavy, while a cart, we're having something loaded. So we're not using our resources in some countries sometimes. So therefore, I want you to differentiate. I'm not going to talk about today, but my colleagues, it's important that we have this meeting. There are three settings that we treat them differently. We have the low resource setting, which is like, can be a capital of one of the countries where you don't have enough resources. But there's the remote and accessible region like Sub-African Sahara. But there is the war and conflict zone. There are three different scenarios, and we should have in our future meeting, Professor Muhammad, thinking about each one of them separately and find solution for them separately, because we cannot mix them. They are too bigger category to have them together. But I want to we claimed and asked me to talk about low difficulty and shortage of diagnostic. But there is another problem, ladies and gentlemen. The problem of overusing unnecessary services to hold great significant in our areas due to limited availability of resources. For example, unnecessary surgical procedure performed in low and middle income countries lead to a high economical burden. And I'll give you an example of the cesarean section in China. The annual cost of doing unnecessary cesarean is $3.3 billion. And then we claim that we don't have equipment or services and doing. There are 1,073 unnecessary appendectomy in Iraq reported with a complication of 3%. So we are doing, I'm not going to talk, Professor Muhammad, about unnecessary cholecystectomy with a silent incidental gallstones. I'm not going to talk about your favorite topic, doing unnecessary bariatric surgery nowadays where it's not needed. And of course, I'm not going to even mention doing unneeded tests. How many times we admit patients and we doing patient with pancreatitis, and next morning we're doing amylase and lipase for 3-5 days. And that's an extra money. If you multiply it by thousands of people, it get the extra a lot. How many times we're repeating the potassium and we're doing a full chemistry 7, Chem 7 when we need to follow the potassium only? How many times we're doing a full CBC with differential when I'm only looking at hemoglobin? How many times I'm repeating tests where it's not needed? That's a waste of resources. How many times we put a drain where we don't need to put a drain and putting a suture with it and then have to remove it and put a dressing? That's an extra cost. How many times we are changing dressing for a wound post-op after 2-3 days where it's not need to be changed? And the list is long if I'm going to talk about that. So please talk about that. And Professor Bastoni, if you allow me at the end, it's a 2-3 minutes to end it. It's just to share a little of my experience being as a global surgery. For me as AG, I worked in almost 4 continents and in a global area, in the remote areas, in the US, in the Emirates and Gulf region, in Africa, mid-Pacific islands and Oceania. And I want to share the cultures and why we have a problem from my point of view. And allow me if I make overstatement. One of our problems compared to the developing country is that when they have a problem, they go through it and they solve it. But if we have a problem in our area, we go around it. We don't even address it because we look at persons and cultural things, and we don't want to have a feeling there or here. When they ask an opinion, what you think of this or that, in the West and the industrialized country, they go straight to the point. For us, we go around and around and around and trying to avoid hurting feelings. When we have a meeting, we have something that punctuality. For us, we say, we'll meet after Asr. It's an open area. So when we talk, this is the noise curve. This is the noise curve for us in red. It's too noisy. And when we have our rights of queuing, it's a different. So that what that, and when we have a bus, the bus is distinguished, but not different than others. For us, we inflate the bus too much that become a barrier to solutions. So in my opinion, over the last 3 decades, I learned that the common challenges that we face is many of us has a fear and insecurity, and that's preventing us from solving. There is a problem that we want to solve everything and have everything, and we want it now. And that's why we don't achieve a lot. And there is a problem of personal gain. The question, what's in that solution for me or my group? The blame and victims. We blame and we like to blame others, not ourselves or them. The state of hopelessness which many of us living in. Many of us or people around me when I was traveling, they advise before they study, understand the problem. We have a problem with conflict and difference between us. And personal stagnation is a major problem where we don't have a clear knowledge of who we are. And we don't have a clear picture of where we want to go. And last thing, which is added by my daughter, Maram, she said, Dad, I notice people a lot that they always have an excuse for anything. And by the way, Professor Muhammad Maram want to give a little talk. And what my advice,
she is more than one.
One of the key secrets of success, in my opinion, Professor Muhammad and Basuni and the group listener, is the power of knowledge. We have to know the importance of possessing knowledge and experience before we give it. We have to have a concept of abundance, that there is enough for everybody and we don't have to fight. We should focus on the outcome, not the process. And we should focus on the circle of influence, not like circle of our concern. We should learn from our mistake and keep the end of stick and end result in our mind. We should agree on limits, rules, expectation, and consequences, and provide continuous feedback and evaluation. One of the most important things is to know that the problem, the way we see the problem, is really the problem. So if you want to change the solution, change the way you look at it, change the paradigm. We should value the differences. It's positive. We should think about changing ourselves before we change others. We should put hands together and synergize, respect each other, communicate effectively, delegate effectively, put first thing first, and seek win to win. And we should remember, I've learned that there is no magic fixes. We love to have magic fixes. They are not available. And remember, throwing money on a problem does not always work. And ideas, they don't work unless we do. And if I have an apple, Professor Muhammad, and you have apple, and we change them, at the end of the day, each one of us will have an apple. We lose nothing. But if you have an idea, sir, and I have an idea, and we exchange them, the good thing, at the end of the day, we have 2 ideas. So we're never going to lose by giving others and sharing with them. Never, ever you're going to lose. And you have to remember that what you do today, professors, their professors are responsible for this meeting, will definitely improve all our tomorrow. But we have to know that 99% of failure from people who make excuses. And which therefore we have to be flexible in our thinking. And this world is a dangerous place, not because those who do evil, but because of those who look on and do nothing. And all necessary for evil to succeed is that good men do nothing. And good people do not need laws to tell you to act responsibly, while bad people, the law. And with saying one thing, professors, we work together, I forget the rest. And thank you so much. And this is my contacts. Thank you.
Thank you very much, Professor Ali, for this very, very informative lecture. And you just reminded me with the old days where we had the most sophisticated investigation was a plain X-ray. Do you hear me? Hello?
Yes.
Okay. The most sophisticated investigation was a plain X-ray, and the most sophisticated antibiotic when I started was penicillin, streptomycin. Now we are abusing, and we are doing something that is really criminal and evil. That is the abuse of antibiotics. I just completing what you have been saying. Anyway, thank you very much, brother. And I'm repeating, we are expecting you next Congress on February, inshallah.